Welcome to our webinar on Kenya, a conversation about sexual and reproductive health and rights in the time of COVID-19. I'm Beth Riven, President and CEO of Uplift International. For almost 25 years, Uplift International has been focused on creating solutions so all people have access to health services, including reproductive health. We believe that all people have the human right to health, and our Human Right to Family Planning Initiative, as we say HR2FP initiative, claims that every individual has a human right to decide if and when to be pregnant, no matter where they live. I want to thank our partners in Kenya for co-sponsoring the event, the Aga Khan University and the International Center for Reproductive Health in Kenya. Kenya has faced many challenges during the COVID-19 pandemic, and today we will hear from panel speakers and discuss the impact of COVID-19 on the reproductive health and rights of women and adolescents. I'm delighted to introduce our distinguished moderator, Professor Marlene Temmerman, who is a recognized and charismatic global leader in women, adolescent, and child health and rights. Currently, she is chair of the Aga Khan University Department of Obstetrics and Gynecology and director of the Center of Excellence in Women and Child Health at Aga Khan University, East Africa, based in Nairobi, Kenya. We are grateful that she is also a board member of Uplift International. Dr. Temmerman's accomplishments and awards are just too numerous to list in full. Briefly, she has served as director of the Department of Reproductive Health and Research at the World Health Organization in Geneva. She was elected senator in the Belgian Parliament in 2007, where she served as a member of the Commission on Social Affairs and chair of the Commission on Foreign Affairs and Defense. In her capacity, she was a member of the European Parliamentary Forum and chair of the HIV/AIDS Advisory Group of the Interparliamentary Union. She is also founding director of the International Center of Reproductive Health at Ghent University, Belgium, with offices in Kenya and Mozambique. The organization is a WHO collaborating center on reproductive health and a UNFPA preferential partner. Professor Temmerman has authored over 500 peer-reviewed publications and books in the area of women, adolescents, and children, health and rights, family planning, HIV/AIDS, and infectious diseases and health systems. She is Professor Emeritus OBGYN at Ghent University, Belgium, and has honorary professorships in South Africa, Belgium, and China universities. I am pleased to hand over the session to our moderator, Professor Temmerman. Before I do that, let me remind everyone to message us in the chat box if you are experiencing technical issues. If you have a question for the panelists, please write your question in the Q&A box. Marlene.
Thank you so much, Beth, and very welcome. It's my pleasure to welcome all of you to this webinar on, indeed, COVID and SRHR in Kenya. Beth introduced me at length, but forgot to say that how we met, because she invited me for a great conference at the University of Washington in Seattle on human rights and family planning and SRHR about maybe 4 years ago, Beth, I forgot, but it was such a great initiative bringing together the medical, the health society, but also human rights, legal colleagues. And we had a great conference, and we decided to do the same in Kenya. However, Beth came to Kenya, we wanted to set up a conference, but it was the year of elections. So a bit difficult. So we decided to postpone it maybe next year. And then it was the year of COVID. So now we decided again to kind of postpone it, but there was elections again next year. So we don't want to wait any longer. And that's why we decided let's make use of the new technologies and the new waves and organize this webinar. So very welcome on my behalf. And I'm very happy to introduce to you this great team of my colleagues at the International Center for Reproductive Health, Dr. Griffin Manguru, who is actually the country director and who will give the first intervention. But we also have this great team at the Aga Khan University, and we organize from AKU together with ICRH. So we have Dr. Ferdinand Okwaro, who is just joining because he was in another webinar. And he is a social scientist and will introduce himself. We have Nella Ndaka, who is a global health researcher, and she is working in a great space on the EU and the AU collaboration. We have Ahmed Ambutran, who is our human rights expert, activist, scientist, and who will give a great presentation on human rights, family planning, sexual and reproductive health and rights in Kenya. And we have Bansi. Bansi is the one, actually, we had maybe the ideas a bit, but Bansi is the one who put it all together and who is really the driver and the key person of this webinar. And Bansi also works at the Center of Excellence. She is a biostatistician by training, but she is a much more than that, a coordinator of many of our programs. So this is a very brief introduction. You will hear them, and we will start without further ado, inviting Dr. Griffin Manguru from the International Center of Reproductive Health in Kenya. Griffin, the floor is yours.
Thank you very much, Professor Malin Temerman, and to all my colleagues in the panel, good evening, and to all the participants and attendees, good evening. And as the slides come up, let me just take this opportunity to introduce myself. My name is Dr. Griffin Manguru. I work at the International Center for Reproductive Health as the director. We do research and interventions on sexual and reproductive health, and I will be making my presentation will focus on family planning use among women of reproductive age during the COVID-19 period. Next slide, Bansi. At the beginning of the COVID pandemic, there were a number of concerns about contraceptive use and about service disruption as a result of COVID-19. And so similar disruptions have been observed in West Africa during the Ebola crisis. And what was noted was actually there were more deaths from service disruption than from Ebola itself. And we anticipated that we would have something similar. So obviously there would be, what we expected was that we would have a shutdown of health services, there would be delays in services, there would be stock out of contraceptive commodities and services, hospitals would be closed and so on and so forth. And we anticipated that this impact would be on vulnerable populations, especially adolescent girls, young women, women living in rural areas, and women living in urban slums. And we had actually projected that globally, that is, not just in Kenya, but if we had disruptions in service that affected at least 10% of women in need, especially in low-income countries, then there would be at least 15 million unintended pregnancies in the course of 2020, or at least within the first year of the COVID pandemic. Next slide. And so what I actually want to present today is compare what we thought at the beginning of the COVID pandemic and what happened at the end. And so a lot of this data is drawn from the Performance Monitoring for Action, the PMA survey. And this is an annual survey funded by the Gates Foundation and led by ICRH-Kenya in Kenya. It's a survey in 9 other countries. And so we collect data annually on FP and FP-related indicators. And what I want to do is to compare between 2019 and 2020 and see what are some of the trends that we noted. So first of all, we noted an overall increase in contraceptive use among women of reproductive age, as you can see from the slides. The blue lines represent women who are married, sexually active married women. The blue line represents women who are unmarried but sexually active. The green line represents women who are married. And what you notice that between 2019 and 2020, we had an increase from around 57 to around 63 among unmarried women. And among married women, we had an increase from around 57 to 61%. And overall, we had an increase from around 43 to around 46%. So what you note there is, of course, contrary to what we thought, we actually had an increase in modern contraceptive prevalence rate among all women. Next slide. Again, so the second thing is we expected that we would have a high number of unintended pregnancies in the course of the COVID period. We didn't. And that's good because while in 2019, we had about 58% of pregnancies intended and about 42% unintended. In 2020, we had about 63% intended and about 37% or 38% unintended. Among those who had unintended pregnancies, about 10% wanted children no more or didn't want children anymore. But about 28% wanted the children later. So either spacing or later pregnancies. Again, as you note, while we expected that we would have an increase in the number of unintended pregnancies, we actually had a reduction compared to the previous year. Next slide. Again, looking at contraceptive or changes in contraceptive use among adolescent girls between 15 and 19 years. Again, we had an increase in the proportion of adolescent girls using contraceptives, and that is comparing 2019 and 2020. At the moment, or by 2020 December in Kenya, we have about 14% of adolescent girls all who are on a modern contraceptive method. Among married adolescents, contraceptive prevalence is about 48%. And among sexually active and married adolescents, it's about 46%. Again, this is an increase compared to what we had reported in 2019. Something extremely interesting as well is that the proportion of adolescent girls who got pregnant decreased between 2019 and 2020. So in 2019, the number or the proportion of adolescent girls who were either pregnant or had given birth was about 18%. In 2020, from the survey, it was about 14%. So basically, there was also a decline in teenage or adolescent pregnancies during the COVID-19 period. Next slide. So in conclusion is that contrary to expectations, we noted basically we had a general increase in modern contraceptive methods. We had a decrease in unintended pregnancies. We had a decrease in adolescent pregnancies. And despite findings, so we had also done a similar survey in June 2020, looking at disruptions in service delivery during COVID period, at the beginning of the COVID period. And what was noted is that quite a number of women in Kenya were afraid of visiting health facilities because they were afraid of contracting the COVID virus when visiting the health facilities. But despite all this, despite the expectations we had, despite the fact that there were fears about visiting health facilities, it seems that the demand and supply for contraceptive services remains steady, which again speaks well of the maturity of the health systems and the ability of the systems to provide contraceptive services. So I'll stop there. We have a lot more to discuss. And if you have any questions as members of the audience, please feel free to pose them. Otherwise, thanks very much. And let me give this back to you, Professor Malin.
Thank you very much, Griffiths, for this excellent, very short presentation and keeping time. So maybe I can invite the next presentation that is done by Dr. Ferdinand Okwaro. Ferdinand, the floor is yours, and maybe you also introduce yourself a bit more at length than I did. Thank you.
Thank you very much, Prof. Malin, and thanks to the organizers, to the audience. I'll say very briefly about myself because of the time, Prof. Malin. My name is Ferdinand Okwaro. I'm a medical anthropologist and currently working at the Center of Excellence, Women and Children of Malin. My area of interest is in family planning and urban development, as well as SRH. And I have done a couple of studies on the impact of COVID COVID-19 on SRHR services. And my presentation today will be on sexual and gender-based violence and the impact of COVID on that. And I'm happy to come in at Griffin's, because in Griffin's presentation, he has said to us that unlike the expectation that if contraceptive supplies and if would be affected, the health systems were more or less resilient. But in the sector of SGBV, we see a totally different finding. And that's why I titled my presentation Between a Rock and a Hard Surface. I'll start by giving a story, which is a real life occurrence that we had in the field while doing our own project here at the Center of Excellence that was looking at the impact of COVID-19 on SRH services in Nairobi, Mombasa, and Kilifi. So this is just verbatim from one of our informants told us. We are currently dealing with this bizarre case of a father who defiled his 15 years old daughter. We filed a case with the police, but when we went there the next day, the girl had changed the story. She said she does not remember the identity of the person who defiled her. And on further investigations, we learned that it was the mother of the girl who had pressured her to recant her story. Her dad was the sole breadwinner of the family, and having him incarcerated would deny them their only source of livelihood. So even without COVID, women and girls always have to navigate very narrow straits where they have to make sometimes such bizarre choices as a matter of their daily life. So I would like to foreground my presentation on that. Let's go to the next slide. This next slide, I'll just want to say one or two things about how we understand sexual and gender-based violence. And this is defined as any act of gender-based violence that results in or is likely to result in physical, sexual, or psychological harm or suffering to women. So the key there is look at physical, sexual, and psychological. When many people talk about GBV or SGBV, we consider either beatings or rape or defilement. We always forget the emotional side to it. But I foreground the picture there just to say there is also a need to look at the sides for the boys. That has becoming very important these days. Gender-based violence is increasingly affecting men. Next slide, please. So just before we look at the impact of COVID, I would also just like to give a background there. 47% is an important figure to look at. In the 2014 KDHS, and don't be surprised that it's very old data, is because this is the last time we did a national survey on a number of articles or variables of health. And 47% of all ever married women in Kenya reported experiencing at least one form of intimate partner violence. So 47 should be at the mind. And physical violence was the most common at 45%, and 20% had experienced that in the last 12 months. Let's go to the next slide. So again, keeping 47%, almost 50%, but now impact of COVID. And this is data from the National Crime Research Center, 92.2% increase when compared January 2020 to June 2020, and the same period 2019, 92%, almost double the figures. But I would also hasten to add that these figures are conservative because we all know in these parts of the world, the cases of SGBV reported are actually less than half. We also did our own research at the Center of Excellence, and we realized it was more than doubling the number of cases during COVID. Let's go to the next slide. It's important here, I want to say this because this is normally forgotten most of the time. We just need to look at the number of figures of women who are either slapped or raped and put it there. But there are other forms of violence that came together with during COVID that are important to look at. These are the fact that in Kenya, 75% of the healthcare force is women. And during a pandemic like this one, more women are exposed to the virus. There were heightened also vulnerabilities with school closures, more for girls than for the boys. And when we're talking about home-based care, in these parts of the world, home work is always done by women. So there was an increase in work expected for women. But also there were also other challenges in accessing menstrual and hygiene support. especially those that were given to girls and women through school or through other institutions that were closed. Socio-economically, more women lost their jobs than men, and also in education, more girls dropped out, even during the home schooling, than boys. Next slide, please. So what were some of the causes, one would ask? Why did cases of SGBV escalate? One is economic. Income losses by men led to male aggressive behavior and stress. And when in the field, women would say, my man comes at home, he has no money. When I ask for money for food, he erupts and starts fighting. And this was seen both for spouses and also for children. And close of institutions. This was a big problem for girls in school, because some of them would get the supplies for menstrual hygiene supplies from the schools. And when the schools are closed, they would now have to get money from local men. A good number of them, the border people with some income. They would buy the girls things like sanitary pads and demand favors from the girls. And when they don't get, they would engage in various acts of violence. The stay-at-home orders, again, most of this violence is perpetrated in the homes. And when you tell the women to stay at home without going out, you're locking them together with their abusers. So this is something that was not taken care of. And lockdowns, especially in the night. Again, men are at home in the night when they start fighting or beating their children. There is no way, they have no way of going out to report. So these are some of them. So this is basically what happened during the COVID-19, just in a nutshell. Next slide. So what would be some of the things, some of the recommendations, or some of the things that could be done to avoid or to mitigate against this escalation of SGBV during pandemics such as COVID? Next slide. Next slide, please. Okay, I think I could just go to that and look at some of the recommendations, just in general. We could go deeper into that. Is economic cushioning for vulnerable groups. Like we already said, economic factors led to increase in SGBV, especially for women who depended on men. For the girls who are going to school, we should have alternative mechanisms for supply of information and commodities for women and girls, especially from the vulnerable homes. There definitely should be an increase in surveillance by law enforcement agencies and also fast-tracking investigations and adjudication. And finally, we should institute non-institution dependent monitoring and reporting for GBV and interventions. Because you realize most of these times, girls and women, if they have to go to report to the facility, to a hospital or to the police, and the police and the health facilities are places where they're avoiding, then they would not report these cases. And look at things such as mobile phone or telecounseling or mobile phone related ways of recording or reporting incidents of GBV. Because you realize many of these times some men would boast and say, okay, what will you do to me? The policemen are busy either taking bribes or handling people who are breaking the curfew, and the courts are closed, so there's nothing you can do to me. So some of these measures led to men feeling invincible against the women. And so in a nutshell, we would recommend that, and we can talk about more recommendations in the discussions. Over.
Thank you very much, Ferdinand. Excellent presentation as usual, with a lot of materials to discuss. Just one question, Ferdinand. We also have some US colleagues. I was wondering, what is a boda driver?
Okay, sorry about that. This is transport that is either on a motorbike or on a bicycle, commercial transport.
Thank you. So we go to our next presentation, and I introduced already in a few words Ahmed, but you have to tell us a little bit more about yourself. And he is really our human rights advocate, lawyer. Lawyers, they usually speak very long, and we prepared Ahmed. We said to the key point. So he will do that.
Yeah.
Ahmed, floor is yours.
I'm going to do my best. My legal training tells me to speak every single word I know in my mind. So I'm really going to try and keep it concise here. Thank you so much, everybody. Good evening and good morning to everyone. My background is in law. I'm currently finishing my master's in international human rights. What I would like to go over is a study we had done with the Center of Excellence in Women's and Children's Health at Aga Khan University in 2019. This was a qualitative study in which we were in Kilifi County, because we had felt that there was a scarcity of qualitative data regarding adolescent SRHR. It's always, people always see statistics, of teenage pregnancy and this many and that, but these stories and the risk factors are rarely presented. So as much as I'd like to keep this concise, could I please go to the next slide, please? Okay, fantastic. So, I mean, the reason why we chose to focus obviously on adolescents is that Kenya at the moment is on bound of a demographic dividend, with almost 24% of the national population being under the age of 20. And it just seems that adolescents seem to be that marginalized group in which human rights just skip over. We often care about the rights of the child, and we focus on human rights in adulthood, but it seems that this demographic really gets to be skipped over. So for a study summary, we did a qualitative study and we chose 3 groups of people that we would be interviewing. The tools and interview guides that we used were based on secondary data we had already collected. The first group was national stakeholders. These would include, I was able to do interviews with heads of members of PATH Kenya, FIDA Kenya, Akili Dada, and the International Center for Reproductive Rights. The second group was community members and stakeholders in Kilifi. These were Kilifi governmental members. These were youth representatives. These were religious leaders. And number 3 was the Kilifi Youth Advisory Council. One limitation of our study was that, unfortunately, we were not able to interview adolescents due to a time constraint. However, the Kilifi Youth Advisory Council were brilliant because we did a focus study with them, and they had the closest proximity to adolescents. So they could really voice, voice the frustrations and concerns of adolescents. As you see there, these were our aims to assess the current access and action taken by the county government regarding adolescent SRHR services in the county, to identify barriers and challenges, to describe the views and experiences of adolescents and stakeholders dealing there with underage pregnancy in the county, to examine the current implementation of constitutional and legal rights, and to identify and recommend any mitigating actions. Once again, I must refer to you that my background is in law. So the reason as to why I call this society versus statute concerning adolescent SRHR is that through my analysis is that Kenya has one of the most progressive constitutional Bill of Rights. Policy-wise, there's so much provision and protections for adolescents. I could sit here for an hour and go through the Health Act, the Marriage Act, and all of these, and really show you the protections and provisions of adolescents. However, from our study, which was a qualitative study with people giving their experiences, we saw that this was not the case. Next slide, please. So from our findings and results, I'll go through them very quickly, and obviously we'll be open to discussion much later. These were put through together from all the themes and sub-themes that we had gotten from interviewing national stakeholders, Kilifi community members, and the Kilifi Youth Advisory Council. So one of the things that really came out was parenting, a culture of parenting that left a lot of neglect towards adolescents. This would leave adolescents to be without supervision, or this would be leading to parents actually using adolescents to provide more for the family. So you'd have adolescents in in basically environments they're not supposed to be at. You'd have adolescents near bars, you'd have adolescents near beach hangout spots that were really, really not conducive to their own health. A mistrust of stakeholders by adolescents. This came out very much while talking to the Kilifi Youth Advisory Council. This came out in the sense that there had been a mistrust building by adolescents through their own political and community leaders, in the sense that they had their leaders there show up for a lot of these symposiums and conferences regarding adolescent SRHR, but the promises were never fulfilled. And so something that really, really came out that was quite interesting was a mistrust of stakeholders by adolescents. Adolescents had this disconnection from their duty bearers. The rights holders had a disconnection from their duty bearers. On a structural level, we had poverty services located geographically far from rural communities. I related this, myself growing up in Nairobi my entire life as an adolescent, I knew very little about any sort of sexual reproductive health or rights information. And I grew up in the capital city. I can only imagine what it was like for adolescents in Kilifi, not being able to access any of these services or information. And these were geographically located in city centers and away from rural communities. Access to basic needs, criminalization of consensual or non-consensual sex between adolescents. I'll talk about that later. And political leaders failing to address and meaningfully engage with adolescents. A human rights-based approach in which we use towards this study, which really focuses on non-discrimination and participation, was really evident in the interviews that we did here. A prioritization of county budgeting for adolescent-friendly services and policies. When speaking to somebody who was the head of a member of the Gender and Culture Committee Department, in the Kilifi County government, they stated something very interesting. And they said that budgeting goes towards what you would call hard results rather than soft results. Now, hard results are things such as infrastructure, roads, and buildings, right? But when you want to invest into something such as mitigation of adolescent pregnancy, it needs to go towards the gender committee in order for things to be changing. Unfortunately, that department in the county government does not receive any funding because of non-immediate results, non-hard evidence results, right? On a programmatic level, county and government duties, not enough adolescent-friendly services and funding of adolescent policies and programs, lack of reporting avenues for adolescents. I think this was touched upon before, which I think we'll talk about later in recommendations. On a societal level, qualitative studies bring out a lot that really that was really, really interesting, I think, just for anybody to go through. There was a religious opposition towards adolescent sexual and reproductive health and rights by community leaders. Community myths and misconceptions regarding contraception and family planning. Customary and community-based resolutions. Now, these would be, for example, I think it was talked about earlier in the case in which a 14-year-old girl was defiled and had to change her story later. So there were things such as defilement dowries that are paid, in the sense that, defilement occurs with an underage adolescent girl, and instead of reporting it to the authorities, instead what is done is a defilement dowry is paid. This could be, giving a bit of livestock to the family, and now the young girl who you defiled becomes your young underage wife, or it's just a payment to the family. Funeral parties such as disco matanga. This, for those of you who are not aware of these are cultural funeral parties that occur throughout the night, and they can occur for about 3 days or so. Unfortunately, they're not supervised. So you have a lot of adolescents showing up to these funeral parties, and there's a lot of drug and alcohol use. And sometimes, speaking to somebody who had worked at the health centers there, you'd have a lot of girls come in adolescent girls pregnant, and they did not know who the father or who impregnated them was, right? These are cultural aspects that I was able to talk to national stakeholders and, get to how we can deal with that. Patriarchy syndrome is just a cultural thing in which girls really just do not have a lot of say in whom they should be with or who they should spend time with. Yet adolescent boys are allowed to be wherever they want to be. Something that was very interesting that came out was how witchcraft was used to stop any sort of reporting. Again, as was said earlier, you would have basically a family threatened with witchcraft if they were to report defilement or rape of an adolescent teenager, and dangerous exposure of minor to adult environment. So what I really enjoyed about this qualitative study was that a lot came out beyond statistics. A lot came out in that we cannot use blanket approaches towards adolescent SRHR. There needs to be cultural understandings and resolutions, towards tackling these issues. And I think now with the pandemic coming up, it's hard to gauge just how much the pandemic has affected such issues. But I think earlier, as was said, there's actually been an increase in contraception use and all that. But I would like to continue. We'll open this to discussion later. Next slide, please. And so just to quickly wrap up on my topic of society versus statute, the Kenyan Constitution is honestly one of the most progressive ones. Article 43 ensures economic and social rights. Article 26 ensures the right to life. Article 26(4), in fact, allows for abortion regarding on the mother's health. And this is open to discussion where this would be physical or mental health, right? So you can't say abortion is illegal in this country, right? In accordance to a medical professional, Article 26(4) allows for abortion, especially if it's going to affect the mother's physical or mental health. Article 27 ensures the freedom from discrimination, which obviously adolescents and youth really face when visiting medical centers regarding their sexual and reproductive rights. Article 53 ensures the rights of the child, meaning all decisions made for the child should be made in the best interest of the child. Just as of note, in Kenya, youth is concerned from anybody below the ages of 35 to 18 and a child under the age of 18. The Children Act, I won't going to go through all of that, but all actions concerning the child, whether undertaken on the private or social welfare institutions, courts of law, the child should be the primary consideration. Next slide, please. Right, the Kenya National Section of Reproductive Health Policy was made in 2003, but revised in 2015 in order to now, in 2010, Articles 2.5 and 2.6 of the Kenyan Constitution basically stated that all international treaties ratified by Kenya were now at the same level as municipal law, meaning those who have had their rights violated could rely on international conventions and treaties provided by Kenya, and they could go to court and rely on this, right? So this was a big thing. A big change to Kenyan law, and that it made it a monist state. So the revision was obviously to increase the protection and provisions for adolescents in the country. The Kenya Health Policy, which gives directions to ensure significant improvement in the overall status of health in Kenya, the first goal of the policy is the progressive realization of the right to health, stating that the government will put in place measures to progressively realize the outlined turnaround and integrate a human rights norms and principles in design, implementation, monitoring, and evaluation. Next slide, please. All right. Lastly, I'd like to finish with just the involvement of adolescents in research in the country. At the moment, we want to know just how much the pandemic has affected adolescent SRHR in the country, right? In 2015, the Ministry of Health put out guidelines for conducting adolescent HIV sexual and reproductive health research in Kenya. They put a 10 to 15 point policy framework out that allows researchers to involve adolescents aged 10 to 19 in research. Just as I've said, for me, a qualitative study in Kilifi was really eye-opening personally, and I think would be a lot of use. And so I just wanted to point out that these guidelines should really, really open up to more researchers involving adolescents, because I feel we need more data on adolescents if we're going to develop policy, if we're going to tackle society versus statute, if we're going to tackle stigma versus statute, right? And by the way, statute, for those of you not law savvy, I'm sorry, a statute is just an act of parliament, that states out what is legal and what is illegal and what the fines are for anything you do illegal. It's I'm sure you've heard of a bill or an act of some sort, right? Lastly, I'd just like to touch on the Sexual Offences Act of 2006, which provides the definitions and punishments for all forms of sexual assault. Now, how this affects adolescents in Kenya is the fact that even though the word adolescent is not referred to in the Sexual Offences Act of 2006, it states that any sort of sexual interaction between any person under the age of 18 is basically a crime of defilement. Now, how this affects adolescents is that if adolescents were to have any sexual interaction, they too are criminally liable for defilement under the Sexual Offences Act. So if a 17-year-old girl and a 16-year-old boy were to have any sort of sexual interaction, that could be a crime. Unfortunately, this leads to a lot of young men, adolescents, either by the family or something reporting to the police. And, you're now leading a 17-year-old boy into a legal system, which can set up, things such as self-fulfilling prophecies, and can be quite traumatizing, having to go through a rigorous criminal investigation in the court system at that age. A recommendation I had made personally was that that I think has been used by a lot of other countries is that sexual interaction between 16 and 18-year-olds should not be criminalized. However, there is a positive note to end on, in that Kenyan courts have now started using alternative dispute resolutions, such as mediation and diversion, when it comes to cases of adolescents having any sort of sexual interaction, meaning that these adolescents do not have to go to the criminal legal system, that these can be done out of the criminal legal system, and there's family reconciliation and any sort of damages and any sort of that. So they don't have to, you're not going to have a 17-year-old boy being held in reprimand or custody with other adults, for any sort of thing like that. So Kenyan jurisprudence and precedence is heading towards at least using alternative forms of dispute resolution for adolescent consensual sexual interaction. Thank you very much. I'm sorry, I know I felt like I've been talking really, really fast. I'm sorry for that.
Thank you very much, Ahmed. You talked very fast, but we know you. You brought a very interesting presentation, and we will have a lot to discuss. So last but not least, it's my pleasure to give the floor to Nella Ndaka, the youngest kid on the block, I think, but she is really, Nella, introduce yourself. She is doing great work in the global health diplomacy, global health thinking, and focusing today on adolescent SRHR. Nella, the floor is yours.
Thank you. Hi, everyone. I hope you're having a good day or a good evening wherever you are. And I'd like to just start by thanking everyone for joining us for this conversation. As Prof. Marlene has introduced me, my name is Nella, and I'm currently working as a research assistant at the Center of Excellence for Women and Child Health in Aga Khan. So my presentation today is on adolescent SRHR in Kenya, and it will be a brief follow-up on what Ahmed has already talked about, and also touching up on what Ferdinand has also shared. So I'll start by, yes, next slide, please. I'll start by highlighting that it's very crucial to understand how to improve access to accurate and comprehensive SRHR information for adolescent population, and also lay foundation for healthy sexual reproductive lives, while also addressing issues that, as we have already heard from the previous presentations, seem to disproportionately impact adolescent girls, such as harmful gender norms, early marriages, or gender-based violence. So pre-COVID, adolescents' access to SR information in Kenya and also to services was somewhat socially stigmatized and scrutinized with restrictions on what kind of information was available and accessible. And so the statement you're seeing on the slide reflects some of the challenges in provision of comprehensive education and non-judgmental health services to Kenyan adolescents. So as you can see, I have highlighted some of the key stakeholders to think about: the teenagers, the parents, religious and community leaders, health providers. But what I really want us to look into as we're reading this is think about how the stakes were high and there were very significant barriers to access to SRHR information, seemingly at all levels. And paradoxically, available research on assessing the provision of comprehensive sexuality education in schools was often being critiqued for excluding adolescents who were not attending schools. And on the other hand, the Kenyan government had been struggling to establish implementation of school-based CSE programs, with evidence revealing that at least 2% of the students learned all the topics that constitute CSE education. However, when you ask the teachers, they would say 3 out of 4 believe that they were giving comprehensive CSE education. So something to think about. So fast forward to COVID times, and now we're asking next different questions. So next slide, please. So with what, next slide, with what Dr. Okwara has already touched on about the lockdown measures, we can see there have been significant disruptions to essential SRH services and supplies. So what I'd like to ask is, how do adolescents in Kenya right now in the pandemic, not that there's been school closures, there's been reduced access to civil society organization working services, how do they access information, and what role can technology play in this? And the reason I focus on digital platforms is actually what you see on the screen, the 3 reasons. And the first one being that worldwide technological innovations are being used to respond to COVID-19, and they're ushering new possibilities in health information and service delivery, including adolescent SRH. So healthcare is increasingly being delivered through digital channels such as the internet, mobile phone messaging, social media, apps, and other platforms. But also, what is very specific to this segment of the population is that young people are very responsive and enthusiastic about digital solutions to health. So for example, we've seen threads on Facebook, on WhatsApp, on YouTube, where people are able to access some online resources. And interestingly, it's good to also consider that most of these resources are open access, but for the few dedicated SRH platforms, very few adolescents actually access these ones. And finally, digital solutions have the potential to tackle some of these key barriers that adolescents in Kenya face. So, for example, what has been mentioned by Ahmed, there's the question of stigmatization and discrimination. And I'd like to add on to that the question of privacy, embarrassment, and high cost to services and transportation. So on a whole, it seems that there's promising opportunities from harnessing existing digital tools for comprehensive sexual and reproductive health. However, these efforts also bring new challenges and might be aggravating existing disparities amongst Kenyan adolescents. So next slide, please. I'd like for us to consider some of these challenges. Next slide. So the challenges that I'd like to address are the 4 that you're seeing on the screen. And the first one I'll start with is the digital divide, which in Kenya denies a very significant proportion of the population access to information. So this is due to structural and technical barriers, such as lack of data, airtime, Wi-Fi. But also I'd like to give an idea of what we're dealing with. In Kenya, the numbers are at 44% for the urban population that has access to internet compared to only 17% in rural areas. So that's what Ahmed was talking about. Having grown up in Nairobi, he can't imagine how this was for adolescents who were growing up in places such as Kilifi. But also, I'd like to bring up another issue, that is delivering SRH services and information could also, using online platforms could also be a good thing, in the sense that adolescents are able to take control of their SRH health, but in some instances, it could pit individuals' autonomy against conservative and patriarchal social norms. And this may in turn put the adolescents in conflicts and at risk. For example, in situations where phones are being shared within families, there's the potential to have issues delivering sensitive personal information. And in the rare cases where adolescents are in abusive situations, you may have their digital media used or controlled by their family members. But going beyond the digital access questions, there's also the risk of replication of social stratification and prejudices online, and also the possibilities of harm and cybercrime, especially for vulnerable population. And so I'd say that while technology has been employed in response and relief measures for enabling social networks and giving access to information to adolescents in Kenya, there seems to be a dual disadvantage when it comes to adolescents who have poor access and to enablement of technology, but also who are significantly disproportionately affected by the digital divide. Next slide, please. I'm sorry, I have to go over this a little bit fast so that we'll have a lot more engaging conversations and discussion on this. So maybe I can share some of my recommendations to address some of these challenges, or also harnessing the opportunities that exist. So I think the very first one is to consider building capacities and resilience for physical infrastructure for provision of adolescent health services. And this could directly address some of the issues that are brought up regarding the digital divide, especially now that service providers are trying to harness existing or new communication channels. And also, this goes hand in hand with making sure that accurate and comprehensive sexual and reproductive health information is made available online, but also across varied platforms, and noting that which information is scientifically valid or medically verified. Because as we all know, we're living in a wealth of information available on the internet, but some of this information may not be necessarily correct or verified. So the need to link this kind of information to also offline resources to make sure that it's appropriate, youth-friendly, and also linking that to community services that raise awareness and encourage follow-up amongst adolescents is quite important. And the second point is on digital literacy. So the provision of digital literacy, goes without saying, should be done in and out of schools so that adolescents can feel confident when they're identifying reputable sources of SRH information, but also within the curriculum, there should be some sort of guidance on understanding and engaging with diverse media that the technology offers. For example, how is data stored? What are the ways to safeguard your privacy? And anything from navigating the internet to downloading and managing applications, I think this is a very essential part of it, especially if you're going to be harnessing digital platforms to share this information with adolescents. And finally, I'd like to conclude with, obviously, as you're making all these recommendations for adolescents, it's important to include them in the conversation. So making them the information available, but also meaningfully engaging with youth as we're designing this intervention, as we're sharing these resources, and as we're also testing these platforms is quite important, so that we can make them, one, accessible, we can also make them youth-friendly, and in such a way that we can encourage their use. So the bottom line here is it's very important to uphold unique and intersectional inclusionary voices for policies such that all the information that is available, that is medically verified, accurate, and timely, and also is non-judgmental, is shared with every segment of the youth population in Kenya. So thank you very much for listening to me.
Thank you very much, Nella, for a great, excellent presentation, keeping time. So now we have about a half an hour and we have seen a Q&A. We have questions in the chat and in the Q&A section. So I'm going to start with Griffins, because there are about 4 questions addressed to you, Griffins, from Alex Omari, from Beth, from Monica Keringen, a good friend, and from Samuel Obak. So I would like you, I'm not going to read the questions, that is a waste of time, but I'm inviting all the speakers to look at the questions addressed to you and maybe summarize and have a first round of responses. Griffins, over to you.
So thanks very much, Professor Malin. There are a number of interesting questions. So the first one is, I think there's somebody who has asked about whether young women and young men used private or public sector channels, and were there any increases in short-acting or long-acting methods? That's a really good question. There's a lot of data, and before I start, let me say that I could direct you to the PMA Kenya website, and you can get all these reports that have been published on this work. So please, after this presentation, you could have a look at the PMA Kenya website. But the short answer to your question is that both public and private facilities were visited. We haven't looked at the distribution of service delivery by facility type, something interesting and maybe a future research idea. But yes, we both public and private facilities were used for FP service delivery. Very interesting question. So we had actually a decline in the proportion or in the number of women who are using implant contraceptives. And I will just pull it from my from the report. So we've had a decline in the proportion of women using implant contraceptives between 2019 and 2020, but at the same time, we have had an increase in the number of women who are using injection contraceptive, that is Depo-Provera. So we had a decrease in the implants, but we had an increase in the shorter acting methods. Of course, as you all know, it would be good, and I'm hoping that during the next round of data collection in 2021, I'm hoping that we will actually see an increase in implant contraception, given that it's longer acting and more reliable. But good question. I think the next question, just very briefly, is what do you think might have contributed to the increase? Were there any innovative strategies? I think the demand generation activities that have been going on despite COVID have been pretty successful. However, one of the things you note, and in my presentation, you also note that I provided trends in contraceptive use from 2014. And what you note is that there has been, or we've had an increase in modern contraceptive prevalence rate from 2014. So basically, FP or contraceptive prevalence has been going up from 2014. So I wouldn't say that it increased because of COVID. The only thing I would say is that it was following a general pattern that has been the case for the last maybe 5 years, and it was uninterrupted by COVID, which I think is a big props to the healthcare system. Prof, I'll stop there so that I can give the other panelists an opportunity, and then I will look at the other questions and I can provide a response later.
Okwaro, over to you. Many interesting questions after your presentation as well.
Yeah, thank you very much, Prof, and thank you very much to the audience as well. So I have 3 questions, and I'll beg to address these 3 and also pick on something that my good friend Ahmed talked about. So we always have this banter amongst ourselves. For the PMA, the question on PMA, on whether PMA has IPV, questions related to intimate partner violence, the answer is yes. And actually, in a study that was conducted during COVID times by PMA and also the ICRH-Kenya and Johns Hopkins University, it showed that in Nairobi, 49% of the youth actually reported an increase in IPV cases. So just in Nairobi alone. So PMA does have questions on IPV. My only worry with that, and also with the data I presented, is that in such questions of SGBV, if you want a national coverage, the nearest data we have is 2014, which is way outdated. And we have another Kenya Demographic and Health Survey to be done next year. So a whole 7 years in between, we don't have any national data that we can use. That's important to also note and to work on. In terms of if there are ways innovative ways to receive real-time data? Again, yes, but these are quite segmented and in some places. An example is the toll-free lines that were used during this time to report cases of SGBV. This is a line where if you had such a case, you easily call, report what you're going through, receive some telecounseling, and that is noted. And in fact, part of the record, the reporting as I gave, the 92.2% cases of increase in SGBV, some of this was recorded from these toll-free lines by the National Crime Research Center. The only thing we need to do is to now look at these experimental forms of data as the real data that we can actually use in the absence of population-based data. We need to innovate more with these kinds of real-time data sources. And on the houses for shelter, yes, again, we do have many houses for shelter for victims of GBV. But then the other nuance I would like to bring out here is, during this time, even these shelter homes were shut down because they needed to be checked that they meet the conditions for isolation, for cleanliness. And the other serious thing that hampered their utilization was the fact that people needed, or all people admitted to these homes, needed to do a COVID test. And there was a time when these tests were actually not being available, and people were stigmatized against them. And so we went, during our fieldwork, we went to this one home at the Kenyan coast, and it was virtually empty because they could not admit any of the victims. Yet they said they knew they had so many victims in the community, and it was all shut down. So a lot of complications coming in with COVID, things that really need to be thought through well. Because one of the suggestions by the people running these homes was that maybe we need to consider fast tracking for victims of SGBV when it comes to COVID testing, so that they can have a safe passage. So a girl or someone has been violated in the community and they need 3 or 4 days to do a test, and then that test comes out, it's already 1 week before they can be admitted into a shelter home. So I would give that response. And now to Ahmed. Ahmed, you're talking about alternative forms of dispute resolution and family reconciliation. If you juxtapose this to the story I started with at the beginning of my presentation of a girl who's been defiled by a father, and the mother steps in to say that, to coerce or cajole the girl to recant the story. When you have such a case adjudicated in the home through family reconciliation in a male-dominated society, that's recipe for disaster. That's what I would say. So I would stop there.
Yeah, I mean, if I could add on to that, Dr. Ferdinand, yes, I totally understand that. But what diversion or mediation means is that the case is officially reported to the courts. The case is officially reported to the courts and put into the court system, right? That there was a case of rape or gender-based violence or defilement, right? It's just that the court does not adjudicate it in a criminal system. It's not going to be the mother and the father of the girl and all that, right? A third party adjudicator, mediator, negotiator has to come in and provide those, and all those have to go into the court statistics. But as you said, yes, it's a very, very difficult situation. Yeah, but at least in this case, a third party has to come in and official statistics have to be given into that. Yes, but absolutely a terribly difficult case. You're absolutely right on that.
Yeah. Great. We'll continue this later.
Kwaro, you want to react? Because the third party is then who? So you have come across this case, right? So is the third party a neighbor, a teacher, a researcher like Dr. Kwaro? I mean, how do you go? What would you advise? Ahmed.
Oh, to me. Oh, right. Okay. Yes. Yeah. No. The third party has to be a court-appointed mediator or adjudicator, right? So everything that is said by all parties, including the defiled girl, the mother, the father, who might have been the perpetrator, right, has to go into court systems, right? And this could, once again, it could lead to incarceration of the father. But if the family do not want to go through that, there will be damages to be paid, and there might be a separation of the father's rights towards his child at that point, in accordance with the Children's Act.
To be continued. Okwaro, did you still are you still answering questions, or do you pass the floor to Ahmed?
No, yeah, we pass it to Ahmed. I think I've responded to the three that that were asked.
Okay.
Yeah.
Ahmed, floor is yours.
Okay. What were my questions exactly?
Oh, I can help you. So if you look at the chat box, one of the questions from Alex Omari is about the progressive legal and policy frameworks in Kenya.
Yes. Yeah. I mean, to that question, I would say that from my research, nothing has been changed since 2015. There's been no additional policy changes or anything toward that. But obviously, the pandemic has been, it's been very, very highly, I would say youth and adolescents have really, really been afflicted. The stories have been in the news of how police have really, really, I don't know how best to put it, but really, really violated the rights, obviously, of a lot of youth and everything. There's been a lot of police brutality. There's been a lot of deaths caused by police brutality. In terms of adolescent sexual and reproductive rights, I think these are cultural issues we have to face towards the stigma, towards visiting a hospital and all that. I think somebody earlier mentioned that obviously now people are more scared to visit hospitals just based on COVID scares and all that. Definitely, nothing policy or legislation wise has changed unless you keep up with the government mandates that are put out every month or 2 months. But yes, things are extremely restrictive at the moment. Yes, I would agree with that. Next question.
So Ahmed, and maybe
Yes.
to everyone, instead of me reading questions or
Yeah.
you, I would kind of invite participants to come in to raise their questions and to have a dialogue.
Yeah.
So one of the next,
if I could,
Beth was sure. Go ahead.
Yeah, I see a question from Beth asking
So Beth
what
can
my
raise her
reflections are. Yeah, around barriers on accessing legal services in Kenya by adolescents from low-income housing. It's really been one of the toughest challenges. One of the recommendations that we had made from our study was the use of community champions. Every community is Kenya is not very monolithical in its culture. You've got over 47 tribes, very different cultures and all that. If you were able to use champions of the community to bring this information that adolescents can access these services and information, it would really, really help. But there needs to be a push from governmental county agencies, NGOs and CFOs to promulgate these rights towards the access of information and services. And it's obviously one of the most difficult challenges when you've got adolescents from low-income households. But when I was doing interviews with the vice head of FIDA Kenya, which really deals with women's health issues, they said our doors are always open. But again, how many adolescents from low-income households even know that those doors are open? So there really needs to be a lot of action of information dissemination towards low-income households and adolescents targeted there. And I see another question.
Maybe can I ask Gladys? Can I ask Gladys to come in and to ask her question?
So yes, this was for Ahmed. I think I got his presentation right, but I'm more concerned about our communities, because I think if we don't address the community and structural, religious and structural barriers at that point, then we may not go far, because these community leaders are very key to us, to many people. We listen a lot to what they say, but yet they are the biggest, I think, probably barrier to
barriers,
especially adolescent response. So I don't know what we would do about that. And my other comment is on the policies and the constitution. Yes, the constitution says FP services should be provided to adolescents. Yes, abortion is legal, but how many even of our service providers know this?
Yeah.
Because I think maybe we have not done a lot in our country to educate the service providers on to what extent these services can be given, including abortion.
Okay.
But again, also our communities stigmatize a lot women seeking these services. So that's also a problem. Yeah.
So Ahmed, so Gladys, thank you very much for the question. And Ahmed, before you respond, it's not only we have a great constitution, but there are, like, for adolescents, as a service provider, you are not allowed to prescribe or to give contraceptives without parental consent, right?
Yes.
So there is a difference between the constitution and the implementation in the field. So maybe you can respond to this.
Okay, so firstly, I'd like to start with talking about service providers. I'm very lucky myself to have a sister who works at Nairobi Hospital, and she's married to a gynecologist. So I was, when I was doing my research for this stuff, it was easy to have a conversation and get some clarification on this. So, when I asked about Article 26.4, which permits, which I'll read it for you out loud, right? Which states that abortion is not permitted unless, Article 26.4, abortion is not permitted unless, in the opinion of a trained health professional, there's need for emergency treatment or the life or health of the mother is in danger, or if permitted by any other written law. Now, when I had asked our healthcare professionals and providers aware of this, actually, the response was overwhelmingly yes. I mean, we can't quote which constitutional, but we do know that. We do know that if the mother's health is in danger, then abortion is permitted. And when I asked the question, is it physical or mental health that's in danger? The response I received was, that's the loophole, And so my response to that is yes, that most medical practitioners are aware of this, but they would not be able to quote the constitutional articles. Sorry, could we get to what were the other questions? The other couple of questions?
So I have a question, if it's all right, for me to ask. It's a question, it's a long-standing question, in fact. After I visited Kenya, and Marlene and I met with a number of civil society organizations as well as experts in the legal and health sectors, it became clear that there was fear in the health sector of being prosecuted by the legal, the prosecutors, the judiciary, and in fact, carrying out criminal investigations and indictments of physicians who are practicing legally under the Constitution and statutes in Kenya. So the big question here is what to do about it when the legal sector, in fact, the full legal sector throughout, judges, lawyers, prosecutors, are actually practicing law, but perpetuating this and undermining this law, I should say.
So we had an incident at ICRH maybe a year back. We ran programs for young female sex workers in Mombasa. And so we had this 14-year-old girl who, 15 or 16-year-old girl, sorry, who was a sex worker, was found at a sex work venue and received, so she came to us and said, you know, I'm a sex worker and I need contraceptive services, which is a bit different from abortion, but similar. And so we provided contraceptive services to her and she went home, and then a month later, she was brought by her grandmother, and the grandmother said that you people are giving family planning to my daughter, who's very, very young. This is illegal. And so the clinician who provided the contraceptive services, plus the program officer, plus a number of staff, were actually led to the police station, had to write a statement, had to say that we are not practicing something illegal, because as it is at that time, the police officers felt that contraceptive services to minors is illegal. Unfortunately, a month later, so after leaving the police station, we went back to the clinic, and the clinician had to remove the implant that had been implanted on the girl who requested. And then 2 months later, she came back and she was pregnant. So again, there's always this thing. And we also did a study in Narok on adolescent and teenage pregnancy, and we found that one of the biggest hindrances towards adolescents who seek and who want and who need FP services is actually the fear of prosecution from the clinicians. Now, one of the things we've done, and I think a very long response to your question, Beth, is right now in Kenya, health is devolved. A lot of people who work in national or at national level understand these laws and practices, but many people who work at the devolved county level do not and are not aware of these practices, and they cannot provide support supervision to health facility staff. They cannot sensitize and they cannot educate direct service providers on some of these progressive policies and laws. So in my opinion, and from my experience, one of the first things is actually to devolve knowledge from the director of health at national level to the director of health at county level and at sub-county level, and to facilitate now the exchange, support supervision from the sub-county and the county levels to the health facility level, because I feel that there's a disconnect between knowledge and practice and understanding between the national and the county level governments. And that's one of the gaps that we can actually start dealing with.
Thanks, Griffiths. And before, because time is running and we only have a few minutes left, and I would like to give the floor to one of the active participants, Samuel Obara, who was asking a lot of questions in the chat box, but maybe starting with your question, Sam, to Nella, about innovation, digital world. So maybe you can talk about that. Over to you.
Yeah, thank you. And the excellent presentation. My reflection was around the issue of the digital technology in addressing or improving access to special youth groups, disability groups, youth who may be LGBTIQ. So what are the experience so far and what could be the recommendation? Because we are saying leave no one behind. That was my reflection around that. Yeah.
Anela?
Thank you. Yes, thank you, Samuel, for bringing up a topic that is quite controversial in Kenya at the moment, given the fact that we all know that same-sex conduct is criminalized according to the Kenyan Constitution. So maybe Ahmed would have a little more to tell us about that, but I'd like to address this from a global health perspective. What happens when you decriminalize certain groups? and marginalize them even further. With the question with access, for example, Dr. Griffiths brought up the example of a sex worker being able to go to a clinic and asking for contraception and having the opportunity to even talk to someone about some of these things. In Kenya, I don't think that is something that is possible for members of the LGBTQ community, for the simple reason that your life could be at risk. And also you're at risk not only from the healthcare perspective, but even from a family setting, from the community, you're at risk for discrimination. So I think the larger question here is beyond the morality clause that is usually used in Kenya, whether it's right or wrong. The question is, what does this do in terms of access to healthcare to certain groups? And the question you brought up about people with different disabilities, I think that's also something that is not quite addressed much in Kenya. I think especially using digital tools, it's something that we could leverage further. So is information accessible to people who are not able to see, people who are not to hear, people who can't access the clinics, who can't walk to the clinics directly? So these are some of the questions that I really think we have not quite addressed at a very centralized level. But what I'd like to also encourage is that we've seen that the civil society organizations are really taking up this space and addressing some of these questions, and that youth advocates are also coming up. And in terms of digital innovation, especially spaces such as on Twitter, on Facebook, on WhatsApp are being leveraged a lot more by disadvantaged groups. So I think it's a give and take, but perhaps I could throw the question to Ahmed, who has more of the legal background, to tell us what are some of his reflections on this.
Yeah.
Ahmed, you can do that if you take 1 minute.
1 minute, okay.
1 minute, and then I'm going to ask all of you, just one final remark before we close. But I allow you to address that question.
So there's been a big movement by civil society groups in Kenya, especially the hashtag repeal 162. 162 is the penal code in which states that there are crimes against morality. This is used against LGBTQI rights, basically, in Kenya, and the judges keep on upholding this penal code. If you see this section of crimes against morality, there's been a lot that have been repealed over the years. They still stick with 162. So the more action, as was said, there are youth groups, there are technological groups that are pushing towards this. This will change. At the moment, the judge is still holding it. Another question to answer is also contraception and family planning for minors under the age of 18. Now, emancipated minors or adolescents, I'm using the words together, minors or adolescents, emancipated minors or adolescents who have already had children, right, have access to contraception. Unfortunately, constitutionally, they are not allowed to have contraception. Yes.
Thanks, Ahmed. That was more than 1 minute, but short for a lawyer. So I'm going to ask the panelists to give a very short final remark before I close and hand over to Beth to close the webinar. Griffiths, what is your thought?
Yeah. So thanks very much, Prof. Malina. And so one of the things I felt, or one of what I've noted, is that in general, there has been a positive trend, increased FP uptake, reduced unintended pregnancies over the last maybe 5 or so years. And I know that many of the panelists got the impression that we have done this during the COVID period, and probably it's one mistake. So what I should have said is actually these are trends that have been observed for the last 5 years. What's important is that we haven't seen a reversal of these trends as a result of COVID-19, which I find extremely pleasing because it shows that the health facilities and the health systems have the capacity to continue providing services, continue creating demand, even in the context of a pandemic. And I think this is very huge props to the government and to especially county governments and to all the implementing partners engaged in SRH.
That's thanks, Griffin. That's indeed the resilience of the health systems in Kenya, despite everything. Thanks, Ferdinand.
Yeah, thanks a
30
lot.
seconds.
Yeah, I'll just say the issue of SGBV is very important, and it's neither an academic or a research exercise. It's a matter of life for girls and women. And we really need to get to the heart of it. We may have as many police, we may have as many courts, we may have many institutions of redress, but until we address that double bind of traditional attitudes of men, the definition of roles and attitudes in relationships, the social economic variables, levels of education, and also the cultural attitudes where men in society feel that simply because they are men with money or property, they are allowed to possess or own women and do whatever they want with them, either slap or have non-consensual sex with them, simply because of being male or being the dominant in any relationship. This must be addressed as a matter of life, not as an academic exercise. And this is
Thanks, Okwaru, and happy that this comes from a man. Ahmed.
Yeah, I'd just like to continue with what Ferdinand said. I think that was fantastic. There was a question Gladys had asked earlier as to how we deal with leaders who sometimes might be in the way of things. And I think just throughout the COVID pandemic, we've seen that the public health system does give its best. If we could address leaders to keep promulgating the messages that we keep on having here, as Ferdinand said, towards GBV and towards the equality of female and towards addressing what in Kilifi they would call Mwenye syndrome, right? If we could please, find champions of communities and also reach out to leaders, sub-county, county, and national leaders, we will tackle this issue. And as I said, it's not a hard result issue in which you will see tomorrow something happen, but hopefully in the 5-10 years, generationally, we can look back on this and say we were taking the right steps. Thank you so much.
Thanks, Ahmed. Thank you very much. Nella, last word. Nella, you're mute.
Yes, I'd like to conclude by saying that as we're talking about the ecosystem with different stakeholders, policymakers, the civil society, the private sector, and as we're moving towards the digital innovation platforms, we should be very careful not to transfer some of these prejudices that we might have offline into the online spaces, particularly when it comes to vulnerable and marginalized populations.
Thank you so much, Nella. And let me thank the panel. I'm very proud of my colleagues for their great presentation, Q&A. I want to thank especially Bansi. We haven't heard Bansi, but Bansi has organized all this. So a great thank you, Asante Sana, to Bansi. And thank you to all of you, the participants who stayed with us and made it a very interactive session. Time did not allow us to address everything. We could go on, as Ahmed is always saying, for hours, but we have to stop. And so I'm very happy, very proud, and I want now to hand over to Beth for the closing words. Thank you.
Well, this concludes the webinar today. Thank you to everyone who participated, and thank you to all of our speakers, of course. A special thanks to Marlene, Prof. Marlene, and to Bansi Ngatia, and everyone in the Center of Excellence for Women and Child Health at Aga Khan University in East Africa, who helped make this webinar happen. Thank you so much, everyone.